Good evening, and welcome to Evening Rounds. I'm Dr. Sasha Pradhan. I am an assistant professor in the minimally invasive gynecology section of the obstetrics and gynecology department at the University of Chicago Medicine. I specialize in pediatric and adolescent gynecology. Today's session will focus on polycystic ovarian syndrome. And we'll be covering the diagnosis and management in accordance with the newest international guidelines. This session is part of our continuing education series for OBGYN nurses and medical assistants. Disclosures, I have no disclosures to talk about today. And we're just really quick, our objectives, describe PCOS, review the most recent guidelines for the appropriate diagnosis, and go through the appropriate management options so everyone can be familiar with what we're counseling patients on. So just as a background, PCOS is one of the most common diagnoses that I generally make in the office, but it is one of the more confusing diagnoses, and it kind of confuses a lot of providers in the community. It's one of the most common endocrinopathies in premenopausal women, with over 10% of women meeting the diagnostic criteria for PCOS. It's characterized by hyperandrogenism, which is cystic acne or abnormal male pattern hair growth or hair loss, ovulation dysfunction, which is the fancy way of saying irregular periods, and the polycystic appearance of ovaries on an ultrasound. How I usually describe PCOS to most patients is that it's sort of an imbalance of estrogen and testosterone, which results in the ovulation dysfunction, causing the irregular periods. And that also causes their hyperandrogenic symptoms like acne or unwanted hair growth symptoms. The etiology is a little bit unclear. There's a hypothesis about the sort of an abnormal transition to puberty, excess luteinizing hormone secretion, and excess androgen secretion, but definitely room for a lot of research and evaluation about, the background of PCOS. So, one of the main reasons that there's a lot of confusion about PCOS is what you're seeing on this slide. There were previously a lot of sort of different diagnostic criteria that people were using, and that has caused a lot of confusion over the years. Some patients will come and say, somebody diagnosed me with PCOS, but then I had another provider who says I don't have PCOS, and that can confuse a lot of patients. So a lot of the times when I see patients in the office, the first thing I really try to do is go through their records and figure out, do they actually have PCOS? What part of their diagnosis has actually been done? What parts are missing? Are there labs that still need to be done? So that's a huge part of that first appointment if someone is coming in either with a previous diagnosis or a concern for a PCOS. So each of these, the 1990 criteria, the 2002 criteria, and the Androgen Excess Society criteria, they all have pretty much very similar things in them. The basic principles being the irregular periods or anovulation, some sort of clinical or biochemical, which is either signs or symptoms of excess androgen production, or lab work that shows excess androgen production, and the inclusion of ovarian morphology or the ultrasound criteria. So this is the new sort of diagnostic criteria or the steps, and it's a little bit more streamlined and much more easy to follow, in my opinion. So these are the 2023 guidelines. There was a very large group of people, multiple societies like the American Society of Reproductive Medicine, the Endocrine Society, the European Society of Endocrinology. So lots of people sort of got together and they produced this 2023 document, which is an excellent document that goes through all the recent recommendation and really provides evidence-based management of PCOS. So what their steps are is number one, to consider if a patient has irregular cycles and clinical hyperandrogenism. Um, so these, and we'll kind of go through in a little bit more detail what irregular cycles means and how to actually diagnose clinical hyperandrogenism. If they meet that criteria, then the other part of it is actually to exclude other reasons why someone might have some of those symptoms. So that includes things like thyroid dysfunction. So we check a thyroid stimulating hormone level, hyperprolactinemia. Prolactin is made in the pituitary gland. So we check a prolactin level, non-classic congenital adrenal hyperplasia. This is a really rare condition that can sometimes mimic PCOS. And so we check a 17 hydroxyprogesterone and ovarian insufficiency. So or early ovarian insufficiency, which is quote unquote early menopause. So we check a follicle stimulating hormone. And if there are some clinical indications, you can also look for Cushing's syndrome, which is a cortisol production disorder. And we test that through either salivary testing or a test called a dexamethasone suppression test. Step two, if they have irregular periods, but they don't have sort of like the clinical signs and symptoms of hyperandrogenism, then you test the blood. And so the big tests here are going to be a free and a total testosterone. And if those aren't elevated, you can check for an androstenedione or a DHEAS. A lot of people just don't go through that stepwise process. They'll sort of check all of these all at once. If any of these come back really concerningly elevated, then we sometimes do imaging, like a CT scan, to look for any adrenal androgen secreting tumors, which could also be producing these excess levels. If someone has only irregular periods or only the hyperandrogenism symptoms, whether it's the clinical symptoms or the blood tests, then you can obtain a pelvic ultrasound to look for the actual ovarian morphology, which is how the ovaries actually look. Do they look, quote unquote, like PCOS? A really important point here, and very important for me, since I deal mostly with adolescent patients in terms of PCOS, is that you can't really use an ultrasound for the diagnosis of PCOS in an adolescent because there's not really criteria that's been established for what, PCOS ovaries look like in an adolescent. So those cutoffs really haven't been established yet. So if you have a young patient who doesn't meet the criteria, but they, something about how they're, presenting or the complaints that they're having, you know, give you concern, then you can say that they have an increased risk, or you're concerned about it, and then reassess at a later age. And that age is usually about 8 years past their first period. So this is sort of like the new criteria and the way that I sort of think about the diagnosis of PCOS. So let's dig like just a little bit deeper into the signs and symptoms. So the first one is, what is an irregular period, right? A lot of VMAs, when they're doing, when they're collecting their chief complaints, the patient would say, I have really irregular periods, right? Well, what does that actually mean? And how do we actually measure irregularity, right? So in the first year of periods, irregularity can be normal. So usually I don't pay attention too much to that if someone's coming in and their first period was 2 months ago. I sort of say it's okay. But past that first year, and less than 3 years after the first period, that interval of what is considered normal is actually a little bit wider. So less than 21 days or more than 45 days from day one to day one of each period, that's considered abnormal. So if it's really short and close together or more spaced apart. And then 3 years after periods have started, so 3 years post menarche, so less than 21 days or greater than 35 days consistently. Or a really important one is less than 8 cycles per year. Um, or if a patient, anyone more than a year past their first period, has a period of 90 days without a cycle. So that's what sort of the guidelines tell us to sort of consider oligomenorrhea or irregularity in terms of how to define an irregular period. So then the next part is the hyperandrogenism. So hirsutism is the um, the growth of excess hair in characteristic areas, so upper lip, chin, chest, the abdomen, upper forearms, back. And these are sort of the different sites that we look at on an exam to evaluate for hirsutism, which is a manifestation of clinical hyperandrogenism. And then this is a Fairman-Gallwey scale, which can be used essentially to give like a qualitative number to hyperandrogenism or this like hirsutism. So during the exam, you can sort of evaluate and give a score, and a modified score between 4 to 6 is considered hirsute for PCOS patients. The usual score is greater than 8, but the guidelines suggest that you can use a lower cutoff between 4 and 6 to qualify for hirsutism. And what you're really looking for is not just a few stray hairs here and there, but you're really looking for the what we call thick terminal hairs. That short, stubbly hair is what you're really looking for, especially when we're talking about the hair growth on the face and things like that. Um, but sometimes this gets tricky because patients will come in and they'll have done hair removal. So sometimes it's not a very accurate measure. They've either waxed or shaved before they come, and so you can't really get a good picture. So I always ask about what they're doing, and how often. So if they're shaving multiple times a week, or they're having to, go get waxes multiple times, that gives me a much higher level of suspicion for someone, as opposed to someone who says, "Oh, I just have a few hairs that I pluck every now and then." Those can be bothersome, but that's not really hirsutism. Acne, or severe acne, is another sign of clinical hyperandrogenism. But the really important part is that it's not super predictive in itself. So if a patient has severe acne along with the hirsutism, that is definitely more suspicious for PCOS or a more biochemical hyperandrogenism as well. Um, and so the other thing is that a lot of people, especially adolescents, are very sensitive about acne and they may come to me already under treatment for acne. So the other thing I ask is, have you been prescribed, ever used anything prescription for acne management, whether it's topical or oral? Um, so that's another question I always make sure to ask. Um, and then the next thing is, so once you're done with sort of the in clinic evaluation part of it, then sort of the next part is to, test. So if you've established that they have irregular periods, and some hirsutism, you're definitely considering PCOS as a diagnosis, but it's not sort of a slam dunk clinical diagnosis, then you can turn to the biochemical or blood test part of it. So here we're testing free and total testosterone, like we talked about. If either one of those values is elevated, it can confirm the diagnosis. If neither one of those, the free or the total, is elevated, then the other uh, androgens like androstenedione or DHEAS can be used. A really important thing is that a patient can't be on a birth control pill when these values are tested because birth control pills increase certain proteins in the body, which can actually decrease androgen levels. So if they've already started a birth control pill, that becomes a conversation whether, we just keep going, or if they really want a diagnosis, really want to know what's happening, then you would need to stop the birth control pill for about 3 months prior to repeat testing. And if at that point becomes important to have that discussion as well, if they're sexually active, they need additional or different contraception. Once these have been tested and you've sort of established that diagnosis of PCOS, there's no need to like keep repeating the testosterone levels or anything like that, once the diagnosis is established. And then again, like we talked about, say that they have irregular periods, but don't really have any of these like acne, hair growth complaints. You do the labs, and the labs are actually normal. Then, if they are not adolescents, say they're, an older patient, older for me is like, in their 20s, if they're coming in. You can use ovarian morphology or polycystic ovaries on ultrasound. Again, like we talked about, this shouldn't be used in adolescent patients. The criteria is follicle number per ovary. That's the most effective ultrasound marker to detect polycystic ovaries in an adult patient. And you need more than 20 and at least one ovary for it to be considered diagnostic. This is really important because the previous and current sort of ACOG guidelines actually say 12, and the international consensus guidelines are definitely saying 20. And so a lot of times, people will come in and they'll have an ultrasound report that says, they said I had polycystic ovaries on this ultrasound, but I usually either get a new ultrasound if that's the only way to diagnose them to really look and count the actual number of follicles, because some people are using the different cutoff level and will say something looks polycystic when it doesn't meet sort of the new diagnostic cutoffs. A lot of times for my patients, they don't get a transvaginal ultrasound, and I only have transabdominal imaging. And for that, or if the image quality isn't very good, you can use ovarian volume greater than 10 milliliters or a follicle number per cross section. So more than 10 in one ovary in a cross section. But those are only in transabdominal or if the image quality is poor. So the next part is the management part. So there's sort of a couple of different things when we look at management or when we think about management for PCOS. The big ones being the actual menstrual management. Then there's the hyperandrogenic symptom management, and then there's sort of the metabolic and cardiovascular risk part of the management. And then there's a mental health component as well that we should address as well with PCOS patients. So going down this list, the first, the menstrual management portion of it. So OCPs or combined oral contraceptives, estrogen and progesterone dual hormone medications are considered first line as management for a couple of reasons. They can manage the menstrual regulation part of it and can help manage the clinical hyperandrogenic symptoms that patients are struggling with. In adolescence, it's really important to choose an appropriate pill. I usually use like a 30 to 35 microgram ethanol estradiol pill for bone health. A lot of times, I'll have an adolescent patient come in and they're on like a 10 microgram pill, which isn't enough estrogen for their growing bones. So, a standard dose pill in a younger patient is really important. Um, but especially in younger patients and a growing percentage of patients who are older also aren't interested in the use of a hormone-containing medicine or aren't interested in specifically a birth control pill. But they do need something for that menstrual regulation and really importantly in adult patients for something that we call endometrial protection. So one of the most important things I talk about is that um, what's the reason for managing periods? The big one is to have some sort of control or predictability or management of the bleeding, right? A lot of times, the PCOS patients I have come in because, they went a long time without having bleeding, and then they had a really crazy period that lasted a month, or they had a really heavy period that maybe landed them in the emergency room or something like that. So we definitely want to prevent those types of bleeding patterns. And then, really importantly, and as they grow, and for older adult patients, a really important aspect of it is endometrial protection. If people continue to have irregular periods, we do nothing for, or they choose to do nothing. One of the things that we know is that irregular periods or abnormal bleeding can be linked, especially in PCOS patients, to a higher risk of endometrial cancer or abnormal endometrial pathology at an older age. And one of the things we're seeing in sort of specifically the pediatric and adolescent literature is we are seeing younger patients sometimes even with abnormal endometrial pathology. So um, it is an important thing to sort of do something for menstrual regulation to avoid sort of the short-term irregularity of bleeding, as well as provide some long-term protection. Like I was saying, a traditional birth control pill can offer that. But other things like a progesterone-only pill, like a like a norethindrone, or a drospirenone, can be effective as well for patients who want those methods or have a contraindication against estrogen. You can also use the medroxyprogesterone acetate injectable. You can use etonogestrel implants or levonorgestrel or a hormone-containing IUD can also be used in these types of cases. For people who don't want to do something that on a regular basis, you can also use cyclic progesterone. You can use a cyclic dosage of micronized progesterone or medroxyprogesterone for the first 10 days, 10 to 12 days of every month. I have some patients who prefer to do this, and that's great because you are having sort of a withdrawal bleed on a regular basis, which is what we would want, again, for menstrual regulation as well as endometrial protection. So that's sort of the period part of it. And then there's the hyperandrogenic part of it. So one of the most, common things, again, is the use of an oral birth control pill. We were talking earlier about how it increases that protein in the body. The protein that it increases in the body is called sex hormone binding globulin, and that specifically kind of binds the free testosterone that's floating around. And so when that testosterone is bound to something else, it sort of doesn't act as much. And so that's sort of how an estrogen progesterone combined oral birth control pill can help with sort of the hair growth acne symptoms that patients are struggling with. If, again, there's a contraindication to estrogen or the patient declines, or if they're not having a good enough response, you can consider the use of spironolactone. This is, again, an anti-androgenic medicine. As opposed to the use of a birth control pill, spironolactone basically blocks the body from seeing the testosterone. Um, and so you can use these, you can up titrate the medication. You can start low and go up over some time as far as effectiveness. But there are some patients for whom this also doesn't work. And that's where then I sort of turn to dermatologists to talk about additional cosmetic methods, especially for things like hair removal, like laser hair removal, or if the patient is continuing to struggle with the acne component of it, using other topical medications or retinols or retinoids to help the patients as well. Um, so these are some of the hyperandrogenic management options. There's significant discussion online, and some patients more specifically kind of talk about inositol. This is a supplement that has become really popular as in sort of the discussion about PCOS management. It's overall has a lower risk and has some potentials for metabolic improvement, but sort of limited benefits in terms of ovulation and hirsutism or hair management or weight loss. Um, and there's not really any great evidence or recommendations that I can provide about, what the actual dosage of the medication, how often to take it, or what kind of inositol to take. But it's definitely out there, and patients ask about it a lot. Um, so the next part is going to be the metabolic and cardiovascular risk component. So all women who have a diagnosis of PCOS, regardless of their weight or BMI, should be screened with blood pressure measurements. They should have a lipid panel at diagnosis, and then continue testing per their risk factors, their glycemic index, or basically a screen for diabetes and prediabetes at diagnosis, and then every 1 to 3 years per their risk factors. Um, the oral glucose tolerance test is the most accurate, but a fasting glucose or an HbA1c can also be used. Practically, we definitely use an A1C level most often when we're, screening for prediabetes and diabetes. And then sleep apnea screening. There is a higher prevalence of sleep apnea in patients with PCOS. And really important part of that is that it's independent of BMI. So, assessing patients for symptoms such as snoring, daytime fatigue, sleepiness, or with the use of like another validated scale. And then when it comes to some of the metabolic management, there are some medications that we can use, the biggest one being metformin. It can be considered alone in adolescents for cycle regulation, but there's limited evidence. Um, the most important sort of part or space in which metformin can be used is for patients who have impaired glucose tolerance or a BMI greater than 30. The combination of an OCP or combined hormonal contraceptive, estrogen and progesterone containing medicine, and metformin has been shown to have great success for these patients. Um, However, for cycle regulation alone, lifestyle changes are actually equivalent to the start of metformin. Um, if we are starting metformin in patients, the big things that I talk about are going to be the starting GI side effects, the big one being sort of some nausea and diarrhea. Those are pretty common reasons that side effects that someone might experience, and some of the most common reasons for stopping the medicine. Um, the starting dose would be about 500, and then increasing every 1 to 2 weeks with a max dose of of about 2,000. Um, and most of the time, I will use the extended release formulation that tends to have less of the GI side effects. So if very uncommonly, if I'm using metformin alone, um, if the cycle doesn't get regulated with this medication, then I definitely at that point advocate for the start of a hormone-based medication for cycle regulation, endometrial protection. But most of the time, I'm using metformin sort of in combination with a birth control pill in order to sort of do some preventative management for things like prediabetes and diabetes. And helping patients with sort of the metabolic management. Um, a lot of the times, once sort of the diagnosis has been established in one of my patients, a lot of what we talk about at the follow-up visits is going to be lifestyle management. So exercise and diet. It's definitely one of the core focuses of PCOS management. Um, and one of the things I talk about is it's not necessarily just the weight loss component of it. It's the importance of establishing, especially in adolescents and young adults, the importance of establishing the pattern of having a healthy lifestyle that includes, a nutritious, healthy diet and regular exercise or activity. Um, for those patients who are not overweight, I talk about weight maintenance, decreasing insulin resistance, and improving their cardiovascular health as sort of the focuses of why lifestyle management and making sure to not be sedentary and choosing a nutritious diet is important for those patients. Specifically, since again, I deal a lot with adolescents, the recommendations are for 60 minutes of moderate to vigorous intense exercise on a daily basis with some resistance and weight training. For adults, um, the recommendations are about 150 minutes of intense exercise or 240 minutes of more moderate exercise, along with sessions of resistance and weight training a few times a week as well. And I really try to emphasize the resistance and weight training part of it. So these can be, things like yoga or Pilates, weights, using resistance bands, any of that really helps with strength training is an important component, not just the cardio part of it. So not just getting on the treadmill and running for 45 minutes a day, that's great. But having this additional component is also really important. And then the diet part, there's not really any evidence that supports any specific type of diet over another, other than the normal recommended population guidelines. Um, a lot of the times, whether my patient is struggles with weight or doesn't struggle with weight, I still offer consultation with a dietitian or a nutritionist for all PCOS patients to sort of go over. They may only need one or two sessions if they don't struggle with the weight component part of it. Um, but it's always great to have someone really go through their diet and pick out what parts they're doing well and what parts need some additional work. Um, and basically, a lot of the times, if I'm doing some of the nutrition counseling, things that I'm talking about is making sure that people are getting enough vegetables in their diet. I use the My Plate method, which sort of recommends about 50% of the plate should be sort of a vegetable or fruit component. A quarter of the diet of the plate should be protein, and then a quarter of it should be the carbohydrate part of it. Rice, pasta, bread. And so really sort of emphasizing the sort of vegetable fiber and protein part of it really helps people and that organizing what their plate looks like and changing the proportion of how we're eating is really helpful when discussing the nutrition part of it. But again, most of the time, I am sending a lot of people to nutrition to have a more formal discussion about that. Um, and then for patients who do struggle with the weight loss and weight component, which is a pretty large, significant proportion of PCOS patients, there are anti-obesity medications that we discussed. Some can use metformin as a way of getting some mild weight loss, but there are lots more medications which are much more effective in patients with significant obesity or who struggle with significant obesity. Obviously, the GLP-1s have become sort of a big mainstay of the weight loss management. And um, these, in addition to an active lifestyle, have been shown even in younger patients and obviously in older adults to be effective for weight loss management. And so if I have a patient who expresses an interest, I always sort of offer it. And if they do express an interest, then I'm, getting them to weight management or the endocrinologist or whoever I can find that for that appropriate patient to have them have a much longer discussion about the use of these medications. But it definitely has become a really important tool in the toolbox of sort of PCOS management in the weight loss management category. And then bariatric surgery. Can also be considered for improvement of weight loss, diabetes prevention and treatment, hirsutism, and ovulation dysfunction management. So, one of the big things with weight loss is that we have data that says that patients who can lose a certain percentage of their weight can have an improvement in their ovulation status. So, that is so bariatric surgery or the use of a weight loss medication or weight loss through diet and exercise can help people have an improvement in their PCOS symptoms, whether it's the ovulation dysfunction or the hirsutism part of it. So, talking about weight and weight loss is an important component of PCOS management. More specifically with bariatric surgery, it does have the international guidelines sort of do talk about that bariatric surgeons can consider a lower BMI threshold for offering bariatric surgery to patients with PCOS. And then the mental health component of it. So, patients with PCOS do have a higher prevalence of moderate to severe depression and anxiety, especially adolescent patients. So, for these patients, screening for depression using, our validated tools that we have, like our PHQ scales, and then obviously, if they are screening positive, strong recommendations for further assessment, referral, and treatment. Um, Really prevalent in the PCOS population is disordered eating. Eating disorders should always be considered in patients who have PCOS, sort of regardless of their weight status. And then a referral if, our screening questions are concerning for further assessment and management. Um, One of the big things is if we're using medication management in patients, limiting the use of agents that may sort of exacerbate PCOS symptoms like weight gain, especially in those patients who have a history of disordered eating. And one of the big things that we know is that not managing anxiety and depression may actually impact adherence to PCOS management and treatment, especially things like lifestyle changes. So, if you have a patient that's really struggling with depression, really struggling with anxiety, you can talk to them for days about, the benefits of exercise and healthy eating. But if we're not addressing one of the big things that's going on in their life in terms of their mental health, then they're going to find it really hard to sort of, maybe join an exercise class or cook at home. So it's definitely important to have a really holistic global view of what's going on and addressing the mental health aspect. Um, And so in terms of like a team approach, me specifically, so I do have a multidisciplinary adolescent PCOS clinic. This is a collaboration between pediatric endocrinology with Dr. O'Sullivan, nutritionists, and me as the pediatric and adolescent gynecologist. So it's a collaborative care model for adolescent PCOS where, we do the menstrual management, we talk about hyperandrogenism, we talk about lifestyle, nutrition, and weight management all in one clinic visit. Um, our dream would also be able to have a dermatologist there, but that's a work in progress. And more specifically, when I'm seeing PCOS patients in my own clinic, because there's a large proportion that I see, not in PCOS clinic specifically, but just in regular gynecology clinic, at any of my sites. What can RMAs do? It's definitely collecting the patient's goal for the visit. So because PCOS has so many different sort of aspects to it, if they do have that, do they want to talk really specifically today about their periods? Do they want to talk more about their acne symptoms? Do they want to talk more about diet, exercise, weight? Is that their goal for the day? And then confirming medications and supplements, that's really helpful. So if they are actually, if are they taking all the stuff that's on their med list, in addition, are they taking any supplements? Um, that is really helpful for me. And then for nurses, knowing the common medications that they might be taking as far as PCOS patients go. And then, if I do start them on metformin, and they're sending a message back like, hi, I'm having, a little bit more nausea. I'm having some diarrhea. Is this normal? Yes, it is actually pretty normal for a lot of patients. So knowing those common initial side effects can be helpful. And then, I send a lot of referrals for these patients, maybe dermatology, nutrition, endocrinology. So assisting with those referrals and helping with that can be really helpful for these patients. And that's all I have for today. And I'm happy to take questions.
I have a question, Dr. Pradhan. You
Yes.
mentioned the adrenal gland a lot. Where is
Yes.
the adrenal gland?
So the adrenal glands sort of sit on top of our kidneys, and they produce a lot of different hormones that are important. But in the case of PCOS, they are the place where things like the testosterone, the DHEAS, all these androgenic hormones are being made. So, sometimes I have, patients who I will test a testosterone or a DHEAS level on these androgenic hormones, and they'll come back really, really high. Um, and so we get worried that there's some extra growth or something on the adrenal gland that's making or producing these. And this isn't really actually PCOS. And so at that point, we'll either get like an MRI or a CT scan of the adrenal glands to make sure that we're not missing something like that.
Along that same vein, then, where's the ovary? Where does the ovary come in play? What hormones do our ovaries make? And how does
Yeah.
this all
Um,
fit into
so
play?
So ovaries also make a lot of different hormones. So estrogen, progesterone, and the ovaries also make some testosterone. And so some of the testosterone production in PCOS comes from the ovaries. So the ovaries also play a big role in sort of the overproduction of testosterone. And, in terms of like the actual testosterone production, and the levels of testosterone, I always sort of have to qualify that statement with patients saying, these aren't, in most PCOS patients, these aren't so significantly elevated. They're not at sort of a male level. They might just be slightly higher than we would expect in a female body. And so, um, But even these slight elevations in the testosterone can cause symptoms like unwanted facial hair or hair growth on like the chest or back, and can cause some of the irregularity of menstrual cycles as well.
With the inositol, the
Inositol, yeah.
inositol, saying it wrong, you mentioned that there might be some metabolic benefits. So if the patients are asking our nurses or MAs about that, benefit of it, what potentially could those metabolic benefits be? And I know it's all theoretical, not proven.
Yeah. So there's thoughts about the benefits of inositol um, in terms of like improvement in insulin resistance, which again plays a big part in sort of the PCOS symptoms for a lot of patients in terms of things like prediabetes, in terms of things like weight. And so there is this, discussion about the use of inositol. And so it's really in that sort of metabolic realm that inositol, that there's sort of maybe an exciting potential for this supplement to be used. But we just don't have enough information about it so that I can feel really confident in telling someone like, yes, you can use just this, or this is the dose that you should use.
What about for older? And I'm like dominating the conversations. If anybody else has a question, please chime in, or I'm going to let her off the hook in a second. But I have a question. So we talked a lot about the meaning of what it means for younger people with PCOS and
Yeah.
concern that if they're not getting a period, it can increase their risk for cancer later on. We just talked about those potential metabolic risks. They're at higher incidence of beginning diabetes later in life. But what happens when they do get to be later in life and they're at menopause age range? Does PCOS have any bearing for a menopausal person? Or how do we even distinguish
Ooh.
what's menopause versus their PCOS?
That's a great question, and I wish I thought about that on a more regular basis, but I don't, since my patients have transitioned to someone like you by the time they get to that conversation. But women can still struggle with the it's really important to understand also that PCOS is a more chronic type diagnosis. So, someone may get diagnosed in their early 20s, but they kind of continue to struggle with different components of PCOS throughout their lifetime, right? So when they're in their early 20s, they might be really struggling with the irregular period and the acne part of it or the hair growth part of it. As they get older, and their goals change, they may, and there's a whole giant part of this that I didn't really address in terms of things like fertility. So as they get older, that might be what they are, that might be sort of the component of PCOS that they're sort of dealing with at the time. And this is, a great place where our REI colleagues sort of step in and sort of take the wheel at that point of time in order to help women with PCOS who are struggling with the pregnancy and fertility aspect of PCOS. And then as women continue to age and they get sort of to the perimenopause, menopause aspect of it, they can still be struggling with the hyperandrogenism symptoms of the PCOS part of it, right? In terms of struggling again with sort of like hair and hair growth, and that aspect of it. And then so yeah, there's sort of different parts of a woman's life. The PCOS might come in different ways.
The weight. And the last question is from one of our nurses, Christina. She said, you mentioned the link between PCOS and sleep apnea and noted that this correlation was independent of weight. And could you elaborate any more on that?
Um, so I don't know if I truly can. It's sort of a line sort of within within the international guidelines. And the takeaway I got from it was generally that just because someone isn't necessarily doesn't necessarily struggle with weight, they may still have that component of sleep apnea. And so there may be something in terms of the way that they're sleeping, or they may need an evaluation from ENT or something like that. But I wish I could elaborate more, but it was just sort of like a line that for me was like the takeaway was I need to screen everyone in terms of sleep apnea when it comes to my PCOS patients. So I generally, if I diagnose someone, then one of the questions that I'll ask is things like, snoring, daytime sleepiness, fatigue. So all of those questions.
Well, thank you very much for this excellent lecture. I really appreciated it myself. I actually learned a lot too. Thank you.
Um, Absolutely. And then I guess the last part of it is to make sure to say thank you everyone for joining us. I hope this was valuable and applicable. And then the next person who is going to be doing evening rounds will be Dr. Katrina Lee, and her topic will be breastfeeding.